Okay, class, so I'm going to make an attempt to make these voiceovers a little bit easier to listen to. So just going over the learning objectives for this week's content. I'm going to be making several small voiceovers so that you can actually listen to them on a playlist on the YouTube channel. So all in all, I'm hoping to meet all of these objectives, but it may be over the course of several different recordings. In case you hear any background noise today, I do have currently meltdowns happening with my 2-year-old and 4-year-old, so pardon the interruption if it should happen. Okay, so learning objectives, as listed here, always and forever, the objectives are going to focus on how your role as the nurse works with these patients with these different disease processes. What does the nursing process look like for you as the nurse taking care of these patients? Understanding your role, not only with cardiac patients, but patients receiving anticoagulant therapy. We are going to touch on Coumadin and on heparin based on some of the disease processes that we cover today. However, you will go into that at a little bit more detail in pharmacology in future weeks. Describe the role and function of healthcare team members essential to the care of patients with selected cardiovascular disorders. There's a chunk of the content today that we're just going to talk about different imaging and diagnostics and why they're done or why they would be necessary, and the nurse's role in that as well. Describe appropriate use of pharmacological agents in the care of cardiac patients. We are going to talk a lot about hypertension and heart failure in class. And we'll go over those some more at that time as well. Describe appropriate diagnostic tests and values, which we talked about. So the first slide in relation to this one, this first PowerPoint that you're going to listen to is kind of a refresher on the cardiac system. What does it do? What is its purpose? What things should we consider? And then we kind of will go into each disease process separately, although they can all contribute, but we're going to focus on each one individually. Okay, selected disorders as listed here. So we're going to cover in voiceovers. I'm going to do one slide that's kind of the introduction and get you thinking about the blood flow of the heart and the purpose of it. We are going to cover arterio and atherosclerosis. We're going to cover hypertension and heart failure in class after in class this next week. Peripheral vascular disease and both arterial and venous insufficiency. Then we're going to talk about different clots, whether it's acute arterial occlusion or a deep vein thrombosis, and your role as the nurse, what you would want to assess for, potential interventions for that patient. All of these have risk factors or things that make person a higher risk of developing. So we'll go over into the risk factors of all of those, and then so as a nurse you want to be doing your education to focus on those that are at risk before they actually develop the complications, versus those that already have the complications, and how your education changes to help them manage that disease process. So those are the selected disorders covered on the syllabus that we're going to go over the lecture for this week. You guys are responsible for the previous content that you've learned. So I included this picture just to give us a visual of the anatomy of the heart in case we've forgotten superior vena cava and the flow of the blood. The next slide will go over the flow of the blood particularly, but just to kind of get a outside picture of what the heart looks like and the different roles that each of the chambers of the heart plays, venous versus arterial. Okay, so on this slide, I want to kind of take you on a little walk with me through the blood flow through the heart. So think back to your anatomy class and remember that all of that venous return, all the blood's coming back to the heart. So it's worked its way through the entire body. It's coming back through the heart and it's entering through the superior vena cava. and that's going to be coming into the right atrium of the heart. Remember the atriums, both right and left, they're smaller and they're up top. Their job isn't as forceful as the ventricles. So it goes through the right atrium, through the tricuspid valve. Remember, tricuspid before bicuspid. You ride a tricycle before a bicycle. So it goes through the tricuspid valve into the right ventricle. The right ventricle then pushes the blood up and through the pulmonic valve. It goes in through the left pulmonary artery into the lung, the left lung. Goes through, gets reoxygenated, does the gas exchange. Then it's going to come in through the left atrium, through the what is it called on here? Oh, the mitral valve, or the bicuspid. And then it's going to come through the mitral valve, and it's going to settle into the left ventricle. And then remember, the left ventricle has to be a little bit bigger than the right ventricle. The left ventricle is pumping all of the blood through the entire body, unlike the right ventricle that's just pushing blood from the right ventricle in through the lungs. So when you're looking at the anatomy of the heart, you can tell which chamber is dependent on the size. So the atriums are smaller. They have a little less work that they're responsible for, whereas the ventricles are bigger, specifically the left ventricle. Then it goes through the left ventricle, excuse me, and then that is pushed out through the aortic valves and distributed blood through the arteries. So that's a little walk through the heart. I want you to be asking yourselves, if I have a patient who has a problem with the atrium, what would I anticipate, or what would that look like versus a patient who's having a problem with the valve? Maybe the valves aren't closing all the way, or a patient who has a problem with the ventricle. So this is a very important pump in the body, and when there's interruption of blood flow, whether it be in one of the chambers or one of the valves, when there's interruption of blood flow, how does it affect my patient, and what am I going to be assessing for, and what nursing interventions do I want to anticipate doing for a patient who has a problem in a different chamber of the heart. So just a little anatomy review for you. Okay, so the vascular system provides a route for the blood to travel from the heart to the various tissues of the body. This is for tissue perfusion. It carries cellular waste to different organs and allows the lymphatic flow to drain tissue fluid back in through the circulation system. So the circulatory system, or the vascular system, is very important. Remember, this is all the blood that's already worked its way through the entire body, has been circulated, and is coming back through the right side of the heart to get more oxygen and nourishment to go back out and do more work. Okay, this picture shows the coronary arteries of the heart. And you can see when we talk about arterial occlusion, or if we talk about an infarct, or where flow was interrupted in the heart, it's talking about these arteries that are actually providing blood, nutrients, tissue perfusion to the surrounding muscle of the heart. So all of these are important too. So you may hear someone talk about a left coronary artery or a right coronary artery, left anterior descending artery, posterior descending artery. It's based off of this that the blood flow to these areas, it's important for the heart muscle itself to actually function. So if interruption is happening in blood flow, an infarct is happening, and that's a myocardial infarct or a heart attack. Okay, so this may be an introduction for many of you of the actual electrocardiogram, or an actual EKG, or an actual sequence of events that happens in the cardiac cycle. So the electrophysiological properties of the heart are responsible for regulating heart rate and rhythm. There's a sequence of events during the cardiac cycle. The phases are generally described in relation to the changes in pressure and volume in the left ventricle during filling or diastole and the ventricular contraction or systole. Diastole is about 2/3 of the cardiac cycle. It consists of relaxing and filling of the atria and ventricles. Systole consists of the contraction and emptying of the atria and ventricles. Right here on this picture, you can kind of see the second blue line from the bottom. That's your actual EKG. So that has the P, Q, R, S, and T wave. The very bottom line tells you where in the cycle you would be hearing what sounds, where you would hear an S4, S1, S2, and S3. Or if you're hearing those, that's where in the actual cycle of the heart you're hearing it. And then you can see here mitral valve and tricuspid valves close. It talks about atrial systole, ventricular ejection, and ventricular filling. So just kind of look at this and take into consideration all the functions of the heart and what you're feeling for and listening for. Okay, so for whatever reason, this is like my 4th time recording this particular slide, so bear with me. It is important for everyone to understand the basic assessment of an EKG. So here gives you, this blue line here in this picture gives you an example of a normal EKG. Starting on the left side of the picture to the right, the P wave is that very first, see how on the picture it's coming down off of a wave, but that very first full wave that you can see is considered the P wave. The P wave represents the firing of the SA node and the depolarization of the atria. So I put here in the notes at the bottom of this slide what depolarization means. So depolarization is the ability of a cell to respond to a stimulus by initiating an impulse. It's also called excitability. So that's that first little bump. Then that same line goes down and then spikes up really tall and comes back down low and then returns to baseline. That's called the QRS. The QRS, remind me to go over this in class a little bit. It may make more sense if I can draw it on the board, because I know this picture might not do justice, but the QRS is the depolarization of the ventricles. The T wave, which is then that next little bump after the QRS, is the repolarization of the ventricles. Okay, we already discussed a little bit about what a 12-lead EKG does. So if you can kind of picture, let's say I stand up on a table in the middle of the classroom and I hand 3 people a camera and I say, okay, you stand to the left of me, you stand to the right of me, you stand in front of me, and take a picture. Well, then I would have 3 views of, say, my heart. What a 12-lead EKG is, it offers 12 different views of the heart. So it's a fuller vision of what the heart looks like. So when you're setting up a patient for 12-lead EKG, you're actually placing 12 different leads on their body to get an actual EKG. This is a true diagnostics. So if you have a patient coming in with symptomatic chest pain, or maybe you feel irregular pulse, or there's some kind of cardiac something happening, the doctor would order a 12-lead. This is an inexpensive, non-invasive test that can give the doctor a very thorough picture of what the heart looks like as far as the electrical activity. This is different from the telemetry monitor. Remember how I said the telemetry monitor may only have 3 leads or maybe even 5 leads? That's as if I hand out 5 cameras and I say, okay, take a picture from 5 different angles. The 12 lead is just that much better. That much more information, that much better, that much easier to diagnose what the problem is. When you get advanced in reading EKGs, you can actually interpret which part of the heart this electrical impulse is happening from. We're not going to get into all of that today. That's another class you can do once you're a registered nurse. Okay, so some cardiovascular laboratory assessments that you want to be aware of. When treating a patient, for example, for atrial fibrillation, one of the treatment options is to go on an anticoagulant. So we need to have an understanding of what blood tests determine how coagulopathic the patient's blood is. So coags are considered the PT, or ProTime, and INR combined. The PT should be in between 10 to 13 seconds. Again, double check. I don't know if I have it right here in front of me, but I would double check with your book. I would definitely go off the numbers in your book. I hope I adjusted these appropriately. I can't find it in the book right at this very second. So make sure that those numbers are represented appropriately in your book. Then an INR is the International Normalized Ratio, and normal should be between 1 to 2 seconds. If you have a patient who's being treated for atrial fibrillation, we have medications on board to help make them less coagulopathic. Then the laboratory results should be between 2 to 3 seconds. Now, if you have a patient that had a heart valve replaced, then their coagulation results for the INR should be even higher. So this is based off the patient's baseline and depending on what kind of treatment that they're getting. The INR is a direct relation with treatment like Coumadin. Coumadin is measured its effectiveness by obtaining an INR level. The PTT is activated partial thromboplastin time. Normal is between 25 to 39 seconds, and that is for patients that have the medication heparin. If they're being treated or if we're trying to get them to be less coagulopathic with heparin, then we're monitoring the patient's PTT. So Coumadin, we're monitoring INR. Heparin, we're monitoring PTT. So I hope that kind of makes sense. Then this BNP is coming up. We talked about this with our fluid and electrolytes lecture. Brain natriuretic peptide. Cardiovascular patients, you would anticipate, right? If they're having any heart failure, that number, normal range should be less than 100. It can get higher. It can get, I think 900 is considered severe heart failure, but like I told you in class, I've seen patients with that number up into 5,000. So it's almost anticipated or expected. If you have a patient in heart failure, you would anticipate that number would be elevated. Again, we assess that as a baseline so we know if our therapies and interventions are therapeutic, if we're reaching a goal for the patient that is appropriate and realistic for them. Okay, some additional cardiovascular labs that we need to be aware of. Cardiac enzymes. I'm sure many of you have heard the term cardiac enzymes before. Troponin should be less than, and I'm not sure why I didn't write these on this slide. Well, take note. Troponin should be less than 0.2. And this is a protein that's released in the heart when injury has occurred. So you would have elevated troponin levels if your cardiac muscle has suffered any kind of injury. Levels elevate within 4 to 6 hours after an MI or myocardial infarct, and they peak within 10 to 24 hours. So with that data, if a patient comes in through an ER hospital setting with complaints of chest pain, you would anticipate the doctor getting baseline troponins, understanding that it's going to elevate within 4 to 6 hours. So if their symptoms are new onset, we may not see an elevation in that troponin off that first blood draw, but you're going to see that the doctor will order a series of troponins. So they may say obtain troponins and repeat every 6 hours times 3 or times 4, because that will get them up into that 24-hour range. Creatinine kinase, or the CK enzyme, is specific to the cells of the brain, heart, and muscle. The CK indicates troponin necrosis or injury. You need to look at, so see how on that last bullet point it says CK, MB, MM, and VB? So I'm going to tell you what they are. The CKMB, is for the heart. The CKMM is for skeletal muscle, and the CKBB is for the brain. So we, as nurses, if it's a cardiac patient, are looking for the CKMB, and that will give us an idea. It increases by 5% of the total CK when an MI has occurred. Increases occur within 4 to 6 hours of the MI, and they peak within 12 to 24, and they return to normal in 24 to 36. So again, this may be, the doctor may order cardiac enzymes and troponin, both the enzyme and the troponin. They may say draw one now and repeat in 6 hours times 3, or however many, because they're looking for that trend. They're looking for when it starts and when it peaks. So a little bit about cholesterol. I left a little note here. Lipid panel, or your total cholesterol should be less than 200. Actually, and I even think doctors like it less than that. I think they want it significantly lower, but again, refer to your textbook for that. Triglycerides less than 150. Your HDL should be greater than 40, and your LDL should be less than 70. Let me see what else I put here. If a patient has elevated lipids or cholesterol, they're at risk for coronary artery disease, which we're going to go to a little bit more later in the slides, but I just want you to get an understanding and an idea of what the different labs are and what they mean. So that's what we're looking for, is if there's any elevation in the cholesterol, because that could indicate coronary artery disease. Okay, so that's going to end our anatomy and introduction and the labs, EKG. That is just to kind of all get you thinking about all things cardiac. I did make reference of atrial fibrillation a couple times in those slides, and we are not going to cover the ins and outs of atrial fibrillation for the purposes of the content for Adult Health 1. So you should be aware, however, because you will be seeing a lot of patients in the clinical setting who have atrial fibrillation or who are receiving treatment for atrial fibrillation. So I wanted to touch on it. That's one of the more common causes of Coumadin or blood thinners, along with valve replacements and, you know, people that have had previous DVTs or previous clotting issues. So I'm hoping that this PowerPoint isn't too long. I'm hoping it will only take you guys less than 15 minutes just to listen to that introduction, just to kind of get you thinking of all things cardiac. Again, there is testable material in the content that we covered, but the main things that I want you to take away from it is to get yourself to trace back and think back to anatomy and physiology and the function and purpose of the heart. If you can understand truly the purpose of the heart and you can see it as an actual pump, it has a very important role because of what it's actually pumping. We talked about that in class as far as why does airway and breathing come before circulation. Well, if there's no good nutrition, nutrients, or blood to circulate, then the purpose of the pumping of the heart is obsolete. So you have to understand that it has an important role to get circulation to all those small areas of the body, those vital organs, the tissue, just cellularly, its ability to get that blood where it needs to go. And that's pretty much what it is it's a pump. And so we'll talk about that in class more on heart failure and what happens when the pump goes bad. Now, what do you do? So anyways, that was the intro. We're going to get into arthro and arterial sclerosis next.